You've been looking at decisions for discontinuation of a TKI among patients being treated for chronic myeloid leukemia. What is this research all about? What were you trying to do?
Well, patients have been treated with tyrosine kinase inhibitors for many years now, and patients who can achieve a very deep molecular response, and this is sustained for 2 years, can go on to a trial of discontinuation of their kinase inhibitor. And studies over the last few years have shown that about 50% of patients, when they stop after sustained deep molecular response, 50% of them will have disease recurrence, whereas the other 50% will maintain remission. And these remissions now in some patients have lasted out to 10 years.
Right, now I suppose part of this is the definition of deep molecular response, because it can be deep or it can be deeper, couldn't it?
Well, there are the criteria that we use to determine the molecular response is essentially based on a log reduction from a standardized baseline level that is set at 100%. So we're measuring the abnormal gene in this disease, which is BCR-ABL. We're measuring the BCR-ABL messenger RNA. We have an international reporting scale. So a level of 0.1% is termed a major molecular response. That's approximately a 3 log reduction from the diagnosis level. We know that those patients who can achieve a major molecular response have a very good outcome. It's very rare that patients, their disease will progress.
So when you're in this low risk category, you can then discontinue. Is that the case?
Well, when you reach this low-risk category of 0.1%, what happens is that the BCR-ABL levels continue to decline, and they can decline another 1 to 2 logs. And studies over the last 6 or 7 years have shown that those patients who reach these very, very low levels that we call deep molecular response, which is about 1 log lower than the major molecular response, and if that's sustained for about 2 years, then those patients can go on to a trial of discontinuation. And about half of those who do stop will maintain remission, and the longest person now is about 10 years off therapy, but about half of them will relapse and their disease recurs and they'll have to go back onto drug.
Is this irrespective of which TKI you use, second generation or imatinib?
Well, imatinib is where the studies have been taken so far. So there's 2 major studies using imatinib. They were very successful. So now there are other studies using more potent inhibitors, the nilotinib, dasatinib. So they are ongoing.
What does this mean to cancer doctors then treating these patients?
Well, I think it means a lot both to their doctors and to the patients. I think the doctors would like to see their patients coming off therapy, particularly if they are having long-term side effects. It's very difficult for young patients who face a lifetime prospect of being on a drug, a daily drug that they have to take, it really does impact their lifestyle.
Patients want to get off drugs. How many of them are you getting off drugs?
Not enough. So we did a study a few years ago where we worked out on imatinib just how many patients will we get off therapy and successfully off therapy. And after 8 years of imatinib, it was only about 12% of patients. So not very many. So now there's a lot of studies ongoing to see how can we get more patients to reach these very deep molecular responses so more patients can come off therapy.
Do you have any ideas of how this might be achieved?
Yes, this can be achieved with switching, in some cases, to more potent inhibitors, or it may be achieved by starting with more potent inhibitors. We do know that patients can reach these deeper responses faster, and a study just published last year showed that those patients who switched from imatinib to a more potent inhibitor did have a higher rate of reaching these deep molecular responses. But the problem is that for patients who are already tolerating imatinib and they switch to nilotinib, it may introduce some further side effects, and there are also some other potentially quite toxic side effects with these more potent inhibitors. So I think For a patient who's tolerating imatinib, a question is, should they switch to nilotinib or dasatinib, or should they just continue on imatinib? What are their chances of reaching a deep molecular response?
What are your interim comments then for the clinical ramifications and how doctors in the real world should be applying this?
So our study that we're presenting at the EHA meeting is to show that there are some patients who are already at a level where if they continue on imatinib, they have a very high probability of then reaching their deep molecular response levels and then qualifying. Whereas others who may just be slightly higher, even with 5 years of follow-up, they won't reach those deep responses.
And busy cancer doctors do have a chance of distinguishing those patients and knowing which ones can have the prospect of getting off the drugs.
Absolutely. So we hope that this study will help clinicians to decide, should my patient continue on imatinib? Is there any hope, or should we go to a more potent inhibitor?